Okay. Good morning, everybody, and welcome to the Sierra Nevada Learning Community. We are going to talk today about how technology can bring agencies, services, and residents together, which I think is a very prescient topic. Kudos to the folks that suggested this last year at this time when I was looking for topics. And this is part one of a two-part series. And I'll talk a little bit more about the second part later in the learning community. I want to introduce my wonderful learning community team. I'm your learning community facilitator, Barbara DeGraff. Carrie Collins and Shane Reserve are my support team, and I want to just thank them from the bottom of my heart. They have been my support team for the last, this is our 12th learning community together. I'm going to be introducing the speakers and keeping track of some of the great ideas you're all going to come up with. Carrie is going to be muting and unmuting folks and telling you a little bit about how the platform Go to Training works. And Shane is going to be helping monitor the chat box, and she's going to help you with any problems. I just saw that somebody has an issue with audio. So that's our team. Carrie, can you start with the guidelines for the learning community?
Yes, so I know there's a little lag over here on my side, so there you go. So all of you have a little arrow that you see that you can click on, and that will open and close a variety of things that you can do. So when you have it open, go ahead and click, Barbara.
Should be open.
You have joined us either by telephone or your computer. When you click on audio, it should show you either click on computer audio, phone, or it should say no audio. If you click on phone audio, you need to enter in the access code and the PIN number. If you don't enter the PIN number and you want to actually raise your hand and say something later on, I will not be able to unmute you. So just so you know that. So just kind of start clicking, Barb, and let's see what else it does here.
Chat.
The chat box. Okay, click again, because I just talked about that. There's also a slight delay from the presenter. So you all see your chat box. So if you click on that little button there, we will be asking you some questions in the process of the day. You're going to want to put those responses in the chat box. Shane will be monitoring that. You can also raise your hand, and then we can unmute you. But like I said, if you're self-muted, there's not a whole lot I can do to unmute you. We're asking that you do not show your camera unless you are one of the speakers. So go ahead and turn that off, because we have like a lot of people that are joining us this morning. That would be a lot of cameras showing. So go ahead and turn off your camera unless you are one of the speakers. And you can raise your hand, we can unmute you, but I have everyone muted, so you don't need to worry if you have background noise going on at your house. Okay?
All right.
Donna, I'm going to turn off your camera.
Okay. Also, we just want to remind you all about the Strategies YouTube channel. For those of you that have not used it yet, we have all of our webinars, our learning communities, everything's recorded. And you have access to that. You can utilize it for trainings, and we really highly recommend that you go and take a look at that. The other thing I just wanted to point out is you do have materials for today. I'll be referring to a few handouts. If by some chance you are unable to access the materials, they're in that gray bar that Carrie was we were just talking about. You just have to make sure that you click on the materials, and they'll pop up, and you should be able to download them easily. If you have any problem, everyone who's on the call, everyone who registered for this and didn't make it today will receive an email after the learning community with all of the material. Okay, what's the mission of Strategies? Hopefully you all know us by now. I know a lot of the names when I looked at who registered.
Barbara, you can forward your slides. We're back on. There you go. Another one.
It's
going.
just a little delayed, I think. I'm on the mission slide. It must just be a little delayed. Is it on the mission now for you, Carrie?
Yes.
Okay, thank you. So Strategies is a collaborative partnership with the Child Abuse Prevention Center in Sacramento, the Children's Bureau in Southern California, and San Diego State University in San Diego. And our goal is to lift the field by providing training, technical assistance, webinars, and learning communities for our family strengthening professionals. Handout number 1 shows you the webinars and trainings that we're going to be having for the rest of this fiscal year, which ends June 30th. Because of the COVID-19, all of our offerings are online, our learning communities. All the trainings have been put online, and the webinars were always online. One of the things I wanted to just mention to you is there is a big change ahead for Strategies 2.0. OCAP has rebid the contract, and there's going to be a new training provider. Trainings will still be available throughout the state of California. The Learning Community Project will change. Strategies is going to be moving to more of a technical assistance provider, and we will be doing learning communities as a part of collaboration and working with child abuse collaboratives throughout the state. But we won't be doing regional learning communities like this. So after next week, Thursday, which is part 2 of this learning community, this will be my last learning community facilitator role with all of you. So I'm sad about that. All of our resources will still be available to you on the Strategies page, and visit it. It's chock full of so many wonderful resources that I would highly recommend that you take a look at. And we want to thank our funder. We've had 12. This is our 12th learning community. Next week we'll make it 13. It's always been my lucky number. I want to also thank my hub in Jackson, where typically we would have these learning communities. I would be in Jackson with my team. Wonderful, wonderful support from the Amador County Child Abuse Prevention Council and First 5 Amador County. And also my remote hosts that I've had from Mono County, Inyo County, Alpine County, as well as Sierra County. Great support, and all of you that have come on. Usually half of my learning community is repeat offenders, people that are coming back again for a learning community. So I want to thank all of you for being with me on this wonderful journey. Our learning community environment, we start on time, we're going to end on time. I hope you can participate in the polls, the chats, raise your hand. Feel free to ask questions. We'll try to unmute you and get your questions. The more we participate, the richer the experience. And practice self-care, whatever that looks like for you. As Carrie said, we cannot see you unless you put your camera on, but we will turn it off because we don't want to have too many cameras going. It's a little distracting. And we cannot hear you. So whatever self-care looks like for you, if you want to do goat yoga, you go right for it. We won't know what you're doing out there in the netherworld. One of the handouts, which many of you have seen before, is our knowledge to action brief about what is a learning community. And I'm going to talk a little bit later about how we want to help you if you want to integrate learning community concepts into your work. But learning communities are here to increase cross-sector partnership. It's really about bringing as many different folks in to address a problem that you are seeking an answer to. So with our COVID-19, for example, we don't just have one entity in the counties working on it, we bring everyone in, and that's the beauty of a learning community. And this is your learning community. This is when you create a learning community, which you can make anything a learning community, a meeting, a training, whatever. It's really about bringing in as many folks from different sectors in to put their input into the work and to really try to address the problem from all different angles and perspectives. And a learning community is a place where you want to bring as many allies as you can. And this slide really tries to have you think about who are some of the allies in your community that can help you do your work better, apply for funds, identify where there may be resources. So that's the idea of a learning community. And again, later we'll talk a little bit more about next steps for learning communities. And for this year, our goal was to continue to focus on building family agency and community resilience. In September, we looked at best practices in trauma-informed care for youth. Then in November, we had a learning community about self-care for staff and the people that we serve. And then February, we talked about rural policies to improve housing, affordability, and accessibility. And then these two May learning communities are about expanding technology in rural communities. So we can support all these goals as well as others. Now, I have a handout for part 2, which I would really encourage you. My goal initially was that we would have a learning community last for about 4 hours. But because we had to go remote, that would be a long time. So one part of the learning community where we're going to talk about Our Voice, which is an app that folks can use to empower community members, that's going to be next week. And you do have to sign up separately for that. So I would encourage you, the flyer is in your materials with a link. And if you have any questions or issues, you know you can get a hold of me and I will help you sign up. And today our goal, again, we're looking at technology. How can we utilize technology to practically apply it to behavioral health, healthcare? How can this reduce isolation and enhance collaboration? And so many of us we've just gotten better and better at it through this COVID-19 pandemic. We're going to look at technology-based programs that can be tailored to a specific issue and challenge. We have Ian Costello from the Corporation for Supported Housing. He'll talk about homeless management information systems. And then we're going to talk about Our Voice at the May 21st Learning Community. And again, we always look at our focus and what are the different practice methods that we are involved in the work that we do. And this last learning community hits on all 4 of these practice methods. You know, in telehealth, which we're going to talk about first, that's how do you enhance people's well-being services? How do you accentuate growth and development utilizing technology through telehealth services? We're going to talk about Sierra Connect and how you can get broadband access throughout our rural communities. And that really helps in all 4 of these areas because you cannot have online services if people don't have access to broadband digital access. That's just key. And in this COVID-19 pandemic, we've seen over and over again this digital divide for the kids and families that have access to the internet and those that don't. And it's really shown a light on this issue. And then when you look at the HMIS system, we're going to talk about how that can enhance community well-being as well as growth and development services. And Our Voice is a great example of civic engagement. So we're going to hit on all 4 practice methods, but we always hope that you'll look at the issue from the perspective of where do I fit in and where's my focus? Because it really does impact the work that we do and how we implement these different programs. And we have 3 speakers this morning. We have Meg Kwong from the Center for Connected Health Policy, and she's going to talk to us about telehealth programs and policies in California, which have changed dramatically in the last few months. Patrick Kane is here from Amador Tuolumne Community Action Agency and Central Sierra Connect. He's going to talk to us about how the Public Utility Commission is using regional consortia to address the digital divide. And then we have Ian Costello from Corporation for Supportive Housing, who's going to talk to us about HMIS and how that can be utilized. I should be done by 10:15. I haven't had a chance to look. I'm almost there. I'm a little longer than I'd hoped. And then we'll have presentations, time for reflection from 10:15 to 11:45. And then we'll wrap up and adjourn 11:45 to noon. And again, I hope you'll participate in the reflection and questions. So, Carrie, you're going to open up the first poll. We'd like to do a little introduction, so get to know who's on the call. Today's participants, we have 39 counties. That says poll open. Organizer must close poll to enable screen sharing.
So the poll has been launched, and you can choose from Family Resource Center or an FRC network, First Five or Child Abuse Prevention Council, other community-based nonprofits, county agency or school district, statewide agency. If you don't see yourself represented on this poll, please feel free to put in the chat box the type of organization that you work for. So we have almost half of you that have participated so far. I'm going to keep it open for a little bit longer. Let you know how we're doing. Keep on voting.
Keep on.
So I'm going to go ahead and close this poll in 10 seconds. 5, 4, 3, 2, 1. Yeah, some of you might not be able to access the poll. Don't worry about that. It's one of those little glitches. Barb, I don't know if you can see that. Can you see that?
I can't. You'll
no?
have to, if you could do it real quick. I cannot see them.
Okay, so we have 10% that are from Family Resource Centers or FRC networks, 20% from First Five or Child Abuse Prevention Councils. The majority of you, 43%, other community-based nonprofits, 22% from county agency or school districts, including social services, mental health, and 6% from statewide agencies, funders, policy capacity builders. Shane, do we have some from the chat box?
Yeah, we have some from the regional center. One from Ruth Ramirez is from the Resource Connection Early Head Start. OVCDC Family Literacy in Yomono counties. Owens Valley, those are our friends from Owens Valley.
Right.
Tammy Muldoon, thank you, Tammy. She's one of our what did you say, Barb? Frequent offenders.
Yeah.
Tammy's here from the FRC and CAPC. Thank you so much. Pat's here from ATCAA, the Jackson office.
Yeah. Amador Tuolumne Community Action Agency.
And Denise is also here from the ATCAA, Central Sierra Continuum of Care. And then Anna from Central La Familia in Fresno County. Yay, they're our friends too.
Oh, we have Bishop Indian Head Start. Woohoo! Yep. All right. So our next poll, we're going to just ask you now. We looked at where you're from, so we get an idea. We have a great mix of organizations. Can you tell us the title that best fits your current role? And Carrie will launch that poll.
Right. And once again, if you can't click into the poll, sometimes it causes some problems. We understand. Just please feel free to put your answer in the chat box. So we have organizational leader, staff working with families. Are you a board member or other volunteer position? Are you a capacity builder? Are you a constituent, a client, community member, program participant? We've had almost half of you vote. I'm going to keep this open a little bit longer. I recognize a lot of names in the chat box. We wish that we could be with you in person. We miss you terribly. So I'm going to leave this open for another 10 seconds. 5, 4, 3, 2, 1.
Take off.
And then let me share the results. So we have 10% of you are organizational leaders. The largest majority, 79%, are staff working with families. 2% board members or other volunteer positions. 8% capacity builders, and we don't have anybody that clicked onto the poll as far as being the client, the community member, the participant.
Thanks,
And
Karen.
Shane, I'm sure there were some comments
Shane,
in the chat box. Yeah.
Yeah.
Family advocate.
Yeah, family advocate, community outreach liaison, homeless youth coordinator, program coordinator, autism coordinator, PACILA instructor. Ooh, what does that stand for?
I don't know.
Peer advocate, ERMHS. We do love our acronyms, don't we? ERMHS coordinator, organizational leader.
I think early maternal health, maybe.
Home visitor. Peer support specialist.
Excellent.
Trixie. Love that name.
Thank you all.
We have a great, and again, we have a great group. We definitely more on the constituent side, which is an example of a group that we do often have a hard time bringing into our programs, but it gives us an idea of where we need to work. How do we, who do we need to bring into our program? All right, so before we get to our presentation, I would like you all to take a moment and reflect. After each presentation, we're going to have a reflection question, but I wanted to start out with one that is really about the COVID-19 shelter in place order. And this is an opportunity for us to kind of help each other. So answer this question: how has your organization stayed connected to your colleagues during the pandemic? A lot of times we are connecting with our staff, with our clients and our constituents, and we'll talk a little bit about that later. But we're wondering, what have you done? Anything fun, anything interesting to stay connected to your colleagues during the pandemic? Feel free to chat. If you want to raise your hand, we can unmute you. I know one of the things I want to thank Shane for doing for us in this pandemic is she was hosting happy hours for us, as well as a book club, which we did online and was really fun. It was a great way to kind of decompress, especially at the beginning of the pandemic when we were kind of getting used to this new way of working. So let's take about a minute and do a few chats, and then Shane will read off some of the highlights to us, and then we'll get into our presentation.
I see Zoom. We're all Zooming. Zoom, Zoom, Zoom.
Zoom, Zoom, Zoom.
It's definitely a verb now, isn't it? To Zoom.
Yep, Zooming. The boomers are Zoomers. There was something, virtual weekly meetings open with icebreaker activities. I saw some other one that looked interesting, Shane, about
group texting. We've been doing a bit of that too. Yeah, lots of Zoom calls. That's my theory as to why everybody's ready to put on their camera, because we're all used to using Zoom now.
We're used to it, right? Exactly.
Right.
So much. Deidre says so much Zoom.
We have a Zoom self-care 15-minute session every day.
Nice.
Mm-hmm.
Virtual graduations. Oh, that's nice. That's fun. That's with your families. Microsoft Teams. Yeah, the Children's Bureau staff, we use the Teams also, which is a little bit different than Zoom in that you can't see everybody. You can only see like 4 people at a time. So. What else? Conference calls. Yeah, WebEx staff, virtual weekly check-ins. I haven't used WebEx yet. I don't know
Dan, that's great.
Lots of email.
Judy, that's right. I was thinking we did that. That was us. Thanks, Judy. That was fun. And we also, I've done online yoga with my niece. She's a teacher in Michigan, and that's been fun. So nice. One of the benefits is you are connecting with people that you don't normally connect with. Meeting with team members via Zoom for library story times and child family development check-ins.
Chelsea says that they have their graduation on the county radio station. That's pretty cool. Yeah, I saw a graduation thing from, I think it was Orange County somewhere, Southern California somewhere, where they had they had a graduation at a drive-in theater.
Yeah.
Oh, nice.
That's a great idea.
Facebook Messenger, WhatsApp.
Yeah.
Yeah. Mindfulness Monday group. That's good. House party. Nikki, tell me about
Mind Matters. I love that.
What is that all about?
Mental health. Lime green gifts and mailboxes to celebrate. The Mind Matters. Excellent.
A dance off. Carrie needs to join that. Oh, Judy Sherman. That was us. Sorry.
That's us. You did it, Shane.
I did. That was fun.
All right. Well, we're going to move on to our presentation because as always, I take a little longer, but I think it's really helpful. And I'll try to summarize these for you in my post-learning community message so that, I'll highlight some of the fun things that we've done. All right. At this point, I want to introduce Mei Kwong, who is Executive Director of the Center for Connected Health Policy. And Mei is going to take her questions after her presentation. We have plenty of time, and so feel free to chat them in or raise your hand, and then we'll unmute you when Mei is done with her presentation. So if you make Mei the presenter, please.
Yes.
Thank you, Ms. Collins. And I'm going to mute myself.
So, Carrie, I just want to check in that you can see my presentation okay?
Looks good, Mei.
Okay, great. Thank you. And thank you for having me here today. Anyone who's curious what CCHP does to stay connected with staff is that we have a weekly staff meeting, but because we are all dog people, everybody's encouraged to share one cute dog video for the staff meeting. But again, thank you for having me here today. You're probably wondering, how does telehealth touch what I do, touch the constituents that I'm trying to help, and hopefully I'll be able to, provide you with that information and maybe make you think of connecting with your constituents in different ways via telehealth as well. So just a few things to start off with. Carrie, I just want to check to see if my slide has advanced for you.
It is not advanced yet, so click on your slide and then push advance. Yeah.
Oh, there we go. There we go. Is that better?
There you go. Perfect.
There we go. Okay. So I am an attorney, so I always have to start off with disclaimers, but my funders also encourage this because I am primarily grant or federally funded. So I do have to put this at the beginning of each presentation. Any information I provide today shouldn't be considered legal advice. It's purely for informational purposes. CCHP always recommends that you consult with legal counsel if you're looking for a formal legal opinion. And if I happen to mention a company or show some sort of product, know that neither I nor CCHP has any type of relationship or financial arrangement with such a company. A little bit of background about CCHP. We were actually established in 2009 as a California telehealth policy organization. We're a program underneath the Public Health Institute, but in 2012, an opportunity to become the federally designated National Telehealth Policy Resource Center through a grant from HRSA became available. We applied for that and we've been serving in that capacity ever since. However, we still work with a variety of other partners on specific projects related to telehealth or connected health, and that's just a listing of some of the partners we work with. Some of the projects that we do track all of the telehealth laws, Medicaid policies, and regulations for all 50 states and the District of Columbia, and we also track them at the federal level. We also act as the administrator for the National Consortium of Telehealth Resource Centers, and I'll explain what that is in a moment. But for some of you, you might be interested, we have been convening a group of statewide organizations and entities that have been interested in California telehealth policies since about 2011. It's grown to about 70 statewide organizations who have tried to work collaboratively together in order to have a more cohesive voice on telehealth policy and what should be put forward in order to help the population and utilizing telehealth a little bit more in getting their healthcare services. The National Consortium of Telehealth Resource Centers is made up of 14 telehealth resource centers. We're all underneath the same grant program with HRSA. There are 12 regional resource centers and they cover specific states. California has its own resource center, the California Telehealth Resource Center. And what these regional resource centers do are they're sort of your front line when it comes to your telehealth questions. So if you have questions about how do I start a telehealth program, or if you have a telehealth program, maybe you have questions about how to refine it, you can reach out to the regional resource centers. There are 2 national centers. CCHP is the one on policy, and there's another one on technology. And because we all work collaboratively together, we do that to maximize our resources and also to cut down on inefficiencies of duplication. But that close relationship also allows you, when you reach out to one telehealth resource centers, you're really getting the other 13 backing them up. So let's say you reach out to the California Resource Center and you have a question, they can't answer it. They go to the other 13, and usually somebody has an answer, or somebody goes out and researches and finds the answer for you. I mentioned that we track all of the telehealth policies, laws, and regulations for the 51 jurisdictions, DC and the 50 states. That is a snapshot of our website. This is a pretty massive undertaking when you do this, because the policies for telehealth have really been changing over the last couple of years. And during COVID, they've been changing even more rapidly. So it does take a while to do updates, and because of the frequency, you need those updates. So typically we do a spring and fall update, and we were in the middle of our spring update when COVID-19 hit. But we did manage to do it. However, the information that's on our website related to this specific map, it's an interactive map, so you can click on a state and it brings up the information for that particular state. That information is good up through February of 2020, so it does not include the emergency waivers or relaxations in reaction to COVID. That's on a separate section of our website. And the reason we did that was because a lot of those policies are temporary, and some, you know, have had expiration dates and had to be extended, but a lot of them will probably not stick around, or if they stick around, they may be in some sort of other form. So we didn't want them in the permanent section until we had a clearer idea of exactly what changes were sticking around. So how has COVID-19 changed our world? Well, this meeting is a perfect example of that. We are sheltering in place, we're distancing ourselves from each other. And one of the main things is we may be distancing ourselves from each other, but we still need to be connected with each other in some way. And technology has played a major role in it. Again, this meeting is a perfect example of that. It was supposed to be in person, but because of the current situation out there, we've gone to this technological platform in which we're meeting virtually instead. And the thing is that this is probably going to alter our reality and how we live our lives going forward. At least for the near future, we're not going to go back to the way it was exactly before COVID-19. So the question is going to be, how do we utilize technology in order to still get those services that are needed out there? And probably some of you have heard, if not all of you, one of the ways when you're talking about healthcare services during this time was the utilization of telehealth. Now, I'm just going to go over, because I don't quite know how many of you are familiar with telehealth. You've probably heard about it recently, but I don't know how familiar you are with like some of the aspects of it. So I just want to make sure everybody's on the same playing field here before I launch into the rest of my presentation, because I might be using some terminology you may not be familiar with. So you may have heard two terms, telehealth and telemedicine. So just to clarify, actually, people have varying definitions for it, and depending on where you're located, states may use one term and not the other. They may use both terms, but sort of rule of thumb, telemedicine is the use of technology to provide direct healthcare services, whereas telehealth is a little bit broader. So we tend to use telehealth more just to be able to have that broader term, that more encompassing definition. So telehealth is the use of technology to provide services from a distance, some type of health services. It may not necessarily be medical services. It could be something such as care coordination, education services, consultation. So it has a much broader term than telemedicine, and that's the term we're going to use throughout this presentation today. Now, underneath telehealth, there are some terms that you might hear and wonder what that means, and one of them is originating site, and that just means where the patient or client is located when the telehealth interaction takes place. Then you have the distance site, and that's where your provider is, the provider who's actually providing some service over telehealth. And then the third term is modality, and that's the way you deliver the care. So telehealth has three different types of modalities underneath its umbrella. The live video one is exactly what we're doing now. It's a real-time interaction over video. Store and forward is a capture of information that's sent to a provider to look at a later time. So it's a storing of information and you're forwarding it to the provider. So think of when you go into your primary care doctor's office, you have a skin condition, they're like, I'm not quite sure what that is. Let me take a picture of it and I'll send that to the dermatologist. The dermatologist most likely is not sitting right at their computer waiting for that email to come in or that message to come in. They're probably going to look at it later in the day and then get back to the primary care provider with whatever diagnosis or recommendations that they have. So it's storing of information and forwarding it. It's not taking place in real time. Then you have remote patient monitoring, and that's continuous monitoring of a patient's condition, and it can be in real time or not in real time. So real time example, think of ICU unit. Your intensivist might not be on site with the patient at the time, but maybe they're monitoring from a different location and they're communicating with staff that are there physically with the patient to do whatever needs to be done. They're monitoring things in a real-time fashion. Then a non-real-time example of remote patient monitoring might be, let's say a client is at home and they have a chronic condition such as hypertension. They're doing daily blood pressure readings and they're sending them to their practitioner, who again is probably not looking at the readings as they're coming in real time, but maybe looking at them at the end of the day or end of the week, and then assessing them and doing what needs to be done based upon those readings that they're getting. So a continuous monitoring where it's not taking place in real time, but they're looking at the information at a later time. And then you have sort of this other bucket of types of services that fall underneath one of those modalities, but don't necessarily mean direct services. So things such as distance learning, where providers can consult with each other over technology. So there's two ways of doing that. Again, for those who maybe have some connection with telehealth in some way, you may have heard something called ECHO, and that is a form of providing grand rounds essentially through the technology. So you have like a provider, a doctor, usually a primary care doctor, who comes to a panel of different specialists and saying, my patient is exhibiting this and has this condition, and then these specialists provide basically their advice back to that primary care provider, who goes back and utilizes that information how they see fit. And then you have something else called e-consult, which is provider to provider consultation. It's a much higher level than probably what's been going on for decades, which is like the curbside consult of like, oh, you talk to a colleague who has a specialty in a particular area regarding a patient that you have, and then they're just giving back some advice of what they think of. E-consult's a much elevated level of that, where they're providing like, charts and information to the patient's record, and then getting that advice back from that specialist. So that's sort of the level setting there for everyone, because I'll probably be using a lot of these terms throughout the presentation, just to want to make sure everybody understood what I was talking about. So if telehealth was so great, why didn't I hear about it before COVID-19, or why wasn't it more widely available? Really with COVID-19, it has brought telehealth to the forefront. It's like made patient and consumer awareness of it much greater. I've been doing this for about 10 years, and before COVID, I think I still had family and friends who were confused as to what I did for a living. So it wasn't something that was really in like the general population's mind, that they really understood it. But if it could do a lot of these things, help with access issues, help with like getting specialty care, why wasn't it used more? And part of it was a variety of issues, but some of it was things that I have listed here, which is like the policy issues or the policy barriers that prevented it from being more widespread. Broadband, which I understand will be talked about later, but I'm sure you understood that. Can't connect, it's not going to work. So you got to have some connection between the two ends there. There was also a concern about equipment costs. It can be expensive if you need certain type of equipment. That actually has become less of an issue over the years, because the cost of equipment has declined fairly rapidly over the years. But that's still, if you're talking about like, a small rural health clinic, they may not have a lot of leeway in getting some pieces of equipment. So that could be an issue for like smaller practices or smaller types of programs who don't have a lot of disposable income to like buy equipment. And then what I mentioned about awareness and education, it wasn't like really prominent or well known among the general population. So I just want to cover what one of the major barriers, which was the existing policies. A lot of the existing telehealth policies do center around reimbursement. How do you get paid? What's paid for? And that can be sliced into 4 areas in like how policy is structured for telehealth. It's one of them is location, and that's really location of the patient, not necessarily the provider, but where the patient's located and if they're in an eligible location. And the policy can be based upon geography, where they say like, oh, it needs to be in a rural area, or site, a specific type of site. Usually what a lot of the reimbursement policies out there say, like they need to be in some sort of medical setting and not the home, which during our COVID-19 time is problematic since a lot of us are sheltering in place. Modality, those modalities I went over just a moment ago, not all of them are consistently reimbursed when you look at some of the policy. The type of provider who's providing the services. So not all healthcare providers are allowed to use telehealth and get reimbursed for it underneath some programs or some payers. And then what services are covered. Not all services delivered via telehealth can be covered or is covered by certain payers. So these are sort of like the 4 areas where you see a lot of the telehealth reimbursement policies broken down into, and where you see some type of restriction or barrier. Now, probably some of this, you're going to be wondering why I'm going over Medicare policy and like some of the Medicaid policies. And part of it is because that really, Medicare especially, drives how a lot of telehealth policy is structured. So I'm not going to go into deep detail for it, but I did want to make you aware. And also during COVID, there has been like a lot of changes, a lot of restrictions being lifted underneath Medicare, because pre-COVID, Medicare had actually one of the narrowest, most restrictive telehealth policies out there. And the impact of Medicare regarding that is a trickle-down effect. So if Medicare had a very limited policy, you saw other payers like Medicaid or private health plans also have a very limited policy. And you also saw them, other sectors of social services mirroring some of like their limitations as well in their policies, such as saying like it can only take place for like rural populations, or it can only take place in this narrow band. So, or these are the only types of providers who can provide services. So I did want to spend just a little bit of time talking about how some of these barriers have been removed during COVID and like the impact that's had. So with Medicare, and Medicare gets tricky because they have kind of 2 buckets in how they approach telehealth. They have their telehealth policies, which a lot of it is dictated by federal law. And then they have this other bucket of policies, which they call technology-enabled or communication-based services. That second bucket, that's essentially using telehealth technologies. Their explanation is it doesn't replace the currently existing services, which is what telehealth does. That's why we can call it something else. But basically what it also does is if they don't call it telehealth, they're not limited by the restrictions that are in federal law. So they have a lot more leeway in like, making it more available. So that's just like 2 areas. And again, why I'm spending a little bit of time on that is that you see that reflected in the states too, these type of policies where they split it into these 2 buckets in the way they provided services. So just as an overview, these are the changes, just very, very high level. We're not even talking 20,000 feet. We're probably talking about like, 100,000 feet now of like the changes that have taken place in response to COVID when you're talking about telehealth. And these are not all of the changes. These are just some of the more prominent ones. So basically, when you were talking about telehealth, you had all those limitations on how you can use it and get reimbursed for it in the Medicare program. Like patient had to be in a specific place. The patient can only get so many services. Only so many providers could use it. You can only use so many modalities. A lot of that has been waived now, and it's been opened up. I mean, there are still restrictions on there, such as, for example, not all the modalities are allowed in Medicare to deliver services. They basically just are still allowing live video. But the most important thing is they're allowing phone now, and that's something that we've seen replicated on the state side as well, in that the phone has become a way of delivering services. Now, pre-COVID-19, actually, the majority of states explicitly excluded phone from their definition of telehealth. California did not. California was one of the states that had left it vague, but a lot of places were saying or had policies either in law or regulations or in the Medicaid policy saying phone does not count under telehealth. However, recognition that not everybody may have access to the technology because they may not have a smartphone or a laptop or even the robust enough connectivity, broadband connection, they're saying we still need to get services to folks. Let's make the phone something that people can provide a service over. And what we've seen also is like relaxation of the site limitation. So as I mentioned before, there were a lot of the policies limited where telehealth could take place. Pre-COVID-19, not a lot of places allowed the home to be a site where you can receive services. There was like a very limited set of services where you can receive that depending on what program you're talking about. If you were talking about Medicare, it was just basically end-stage renal disease services, or if you were diagnosed with an opioid use disorder, you can receive those services at home, and co-occurring mental disorders that were diagnosed with that. California Medicaid, California actually was in a better position going into COVID with their telehealth policies because California Medicaid had just updated them back in the summer of 2019, and they greatly expanded them. So California, the home was not a particular issue for most providers. It was still an issue for other providers such as federally qualified health centers and rural health clinics. So there was still some work California even had to do, even though they had like probably the most expansive Medicaid policies for COVID-19. But there were still those tricky sort of other policies that were still there. Other things that were sort of expanded were the types of services that could be covered as well. So again, California was in a better position, but what Medicare had to do is that they had to expand it too. And then you've probably also heard, if you've been listening to some of the telehealth news at all or had like a passing interest in it, that they were saying they were relaxing HIPAA requirements or loosening that up. As a resource center, I've always been encouraging providers, even during COVID. I said, and that still act like it's still in place because they just said that they'll exercise discretion, they won't fine people. There's no guarantee they weren't going to do that. But even that has become something to ease this time and ensure that people can get services. And one of the ways is through technology. But there are still concerns that there may be HIPAA requirements that like still impede that. So even relaxing some of these other laws that are not specific to telehealth but related to telehealth in some ways was going on too. So what states are doing, and again, like Medicare, there were some states that were a little bit more restrictive in what they were doing around telehealth, and they were all different too. So this, you can see kind of like the variety of differences here. Like everybody did live videos, throwing forward remote patient monitoring modalities, which were not as widely reimbursed, and usually there were a lot of caveats, like they were, again, that limiting of services, they were limited to some type of service in which you can use that modality, but not for other things. So that was sort of the situation before COVID. Another thing on the state level that impacts telehealth and its usage is what private payers do, so commercial health plans. I've been talking about up to this point Medicare and Medicaid, but you also have like private plans. What do they do? What are they required to cover when you're talking about telehealth? So that varies. So that's actually up to about 43 states at this point. So 43 states and the District of Columbia have some type of private payer laws, but again, like their Medicaid policies, they vary widely. You can have a state that says health plan, you may cover telehealth if you wish to, all the way to health plans, you shall cover telehealth services the same way you would in person. And by the way, you have to pay the same amount, and then everybody kind of falls in between. California had just updated their law last year, though it does not go into effect until 2021, of being more at the other end of saying you're going to cover it and pay the same amount. So again, that's like another area where you're seeing differences and varieties in like how telehealth is covered too. So again, some of the common policy changes that we're seeing is allowing phone on the state level, allowing phone be an eligible modality in which to provide services, allowing the home to be the originating site. Less common modalities they're seeing is expanding modalities. Not a lot of people are talking about remote patient monitoring, and Storm Forward is allowing that. They're focusing on live video and phone in which to deliver services. Expanding a list of providers to include others such as allied health professionals. So this has also been a problem, and probably a little bit closer to what a lot of you are doing, in that this limited list of eligible providers is usually restricted to doctors, nurses, psychiatrists. Sometimes licensed social workers can be on there as well, but you had like really a lot of other health professionals who could provide some type of service via telehealth, and they weren't on there. Behavioral analysis sometimes were on there. That was like an oversight California has had for years, and we just got that fixed fairly recently in the Medicaid program. So that's where some states have been expanding this, and again, California again was in one of those better positions where they had that more expansive policy before COVID. But that has also been an issue, and part of that has been is because on the Medicare level, they had a very small list, so they had a very restrictive list as well, and that was changed during COVID. But with all these COVID changes, again, they're only temporary. We're not quite sure what's going to stick around. Also missing from the eligible provider list, which could have a lot of impact on what you guys do, were federally qualified health centers and rural health centers. They could be that site where the patient was located, but they couldn't necessarily, in a lot of states and with Medicare, provide that service to the patient. They could in California, but they were limited in what they can do when the patient was at home. It had to be a certain type of patient then where they were concerned. That again was temporarily waived for COVID. But you can see where, if you limit your list of eligible providers, it could have like a severe impact on what you can do with telehealth. And probably I would think that might impact this particular audience, you guys as well. And then consent requirements. A lot of states, California included, do have specific consent requirements before telehealth can be used. Again, something probably important to you guys if you do want to start incorporating telehealth. That could be, that is something that to keep in mind, is that you would need to get a consent form in order to, before you can start doing telehealth. Okay, so what did California do? As I said, California had updated their policies back in the summer of 2019, became one of the most, I would say probably the most progressive at that point with their Medicaid telehealth policies. What they had to do really were kind of like those, I don't want to say smaller, but those other types of things that like the sweeping policy just didn't like capture, because it was some quirky requirements such as, explicitly allowing the phone to be an eligible modality in which to deliver services, allowing expanded capabilities for FQHCs and RHCs to use telehealth, relaxing some of the consent privacy requirements because those were embedded in law. And I would have to say that overall during COVID, the administration has been very responsive, and I would even say CMS with Medicare as well. We've seen like really a lot of quick action. That's been the fastest I've ever seen administrations moving on telehealth policy. So they have been pretty responsive. They have been listening with an open ear on like some of the things the telehealth community has been saying back to them, saying, X is an issue, can we get some guidance or can you fix it? And there's usually, I would say most of the time, they're able to address it fairly quickly. So what is it going to look like in a post-COVID world? Nobody's quite sure. And about maybe 2 weeks ago, I would say I had not heard anybody really discussing what this is going to look like. Are any of these changes going to be sticking around? I'm starting to hear the talk about that now from policymakers. So I think some of these changes, some of these waivers, we're going to have them stick around in some form, and others we won't. So some of the things that likely are sticking around are relaxation of, the type of provider who can provide a telehealth service. I think they'll probably expand like what you can do in the home, because again, this is not going to be, not going to revert back to pre-COVID way of life immediately. You're probably still going to have a lot of people, especially vulnerable populations, who are still sheltering in place. And also, I think this opened up discussion for some of the major issues that we've had in the past, but we haven't like really solved them yet, such as the broadband connectivity issue as well. Licensing has been a big issue. That's always been a hot topic before COVID-19. I think there's going to be more serious discussion about it now when we get into like sort of what do we want to keep around, what do we want to change. One of the things that I think is going to go back is the HIPAA, the relaxation of the HIPAA requirements. That's going to go back to what it was, but I do wonder if that opens it up for discussion of, hey, there's nothing in HIPAA really directly related to telehealth. Maybe it's time we have that discussion, and that's going to like start another discussion of like, we need to update HIPAA now to keep in mind that telehealth is now available. So these are the policy, I mentioned that some of the policy changes that will, still sticking around. One important one is the digital divide. So what COVID has also exposed with like this greater interest in telehealth is that we do have this digital divide out there. That's why you have to rely on the phone to like provide some services, because again, not everybody has access to the technology personally, like a smartphone or a laptop, or maybe they're not able to like utilize it. For example, my mother just had like a doctor's appointment over video, which she would not have been able to do unless I helped her with it. So there's going to be, populations that and segments of the community who could be left behind if we go forward with telehealth and becomes more integrated in the healthcare delivery system. It's like, what do you do with those people who may not have access to that technology or have trouble working that technology? You don't want to leave them behind, because they probably are some of your most vulnerable population, probably the populations who are sheltering in place and need to do that for a longer period of time. So that's definitely something that's in a lot of people's mind that is also going to be, among the areas of discussion as well. Now, probably a lot of you are saying, like, why did I sit through this presentation? I'm not in healthcare. We don't provide direct healthcare services. How does this impact me? Well, a few things. For one thing, as I mentioned earlier, telehealth is not only just a provision of healthcare services. It's a lot of things. And I'll give you some example of where it's used that you may not have thought like, oh, there was an application to it. Criminal justice departments, the criminal area, where would you use telehealth for that? And you're probably thinking like, well, maybe corrections. You can provide healthcare services in a prison. You can do it via telehealth. That's a way of doing it. But that's not the only way or only area in where telehealth has like an influence of. There are programs out there where they use telehealth to treat sexual abuse victims, where they can do the have a sexual assault nurse do their exam via telehealth. So that is one way in which telehealth has intersected with like another sort of sector of in our government as well. There's also programs out there, one in South Dakota that got a bit of press before COVID, where they were using telehealth to provide mental health services, behavioral health services, counseling services to foster youth or youth in the criminal justice system. And what they noticed was that the recidivism with that has been much better when they were receiving those services, that they were less likely to continue down a wrong path or get in trouble more, that they with these provision of these services, they help them adjust better to life out of a foster system. So there's like a lot of uses for telehealth that you may not necessarily think of beyond just in in this segment of healthcare. It's other areas as well. For coordination, so there have been uses of telehealth in coordinating social services, different types of services, because now you have this technology here where you can connect to different types of agencies in order to coordinate those services, such as for example, for food stamps or maternal health training, educations, and access to other types of services in the social services side that aren't specifically underneath Medicaid or specifically like a healthcare type of program that you may think of. Education, one thing that I've heard of sometimes people doing, especially health clinics where they have the telehealth equipment, and they are saying what do we do with this when we're not having our telehealth clinic? They've been opening it up to the community to allow them to do some sort of educational services to other people. Perhaps maybe some type of nutrition group meetings as well, or smoking cessation programs, or just even training for mothers on breastfeeding. So there's actually telehealth programs out there to help mothers learn how to breastfeed if they're having some issues. One thing also where CCHP has been contacted, and I've been working with them. I've been working with the California Caregivers Network, where they are asking we want to try to use more telehealth in order to provide the support services to caregivers. How can we do that? Yeah, another sort of education training or just sort of like, you know, that connection where you have somebody to go to for some resources if you're a caregiver and you're having some issues. And the thing I just want to stress is that this is something you need to consider if you're not already considering technology, because it really will be integrated as a way of life for us going forward. We're not, I keep repeating this, we're not going to go back to exactly the way we were right away pre-COVID-19. So we're still going to need to find a way to still connect with people from a distance. And telehealth, especially if it's already been set up with like a healthcare system or like with a clinic, is an option out there for you to consider and to like utilize and use that as another tool. Still not saying like all in-person needs to go away. It doesn't. There's going to be some, even with telehealth for healthcare services, medical services, you're still going to need to do some in-person stuff. You can't do everything over telehealth, nor should you. But for some of the things that you can do, utilize technology. It's just another tool that you have there available for you in your toolbox.
May, I think we have to wrap it up because we're way over, and we have a
okay. Yes, and these are just the last few slides that you have the PowerPoint on. I just wanted to say California just launched a telehealth consumer website. That's the URL. There's an HHS website that they launched a few weeks ago, and then just some CCHP resources, and that is it.
Thank you so much. That was excellent. I wanted to just make a comment. Carrie, you're going to make me the presenter again?
Yes, I will do that right now.
Okay. Because we have a reflection question, but I wanted to just make a comment that, you know, you'd mentioned, May, about your mom and, you know, a lot of people using telehealth that haven't used and not just for health, but for behavioral health, et cetera, et cetera. And I just wonder if we as family strengthening professionals, one of the things we might be able to do with our clients, because we have a connection with them, is offer like practice sessions for them. You know, because it's a little scary for people. How does this going to work? You know, but if you can give them practice sessions, it sounds simple, but I think it would really be helpful to our population of some of the folks that we work with.
Definitely. And actually there was a clinic that I was talking to just a few weeks ago who, during COVID, in reaction to COVID, they actually had to start a telehealth program. I mean, like within like basically over a weekend. And one of the things that I thought they did was great was they offered a practice session to patients before their actual meeting.
Exactly.
So that's a wonderful idea.
And we have a question here. Judy Sherman said, how can we advocate for continued access that has been advanced since COVID?
So you can join the Telehealth Policy Coalition. That is what the coalition has been looking at as well. You can talk to your representative, your state legislator. I can tell you right now, there's a lot of California state legislators who are interested in telehealth. So the interest is there. One problem though that you're probably going to encounter, everybody's going to encounter, the budget outlook is not that great.
Right.
So it's going to be tricky, but all recommendations are, but you still got to focus in on the health side of things. So you can't really skip on that. So I would say you could join the coalition and also talk to your representatives, because representatives both on the federal and state level are very interested in telehealth.
Excellent. Thank you so much, May.
What was the name of the coalition again?
It's the Telehealth Policy Coalition. If they're interested, just send me an email. We do the membership thing. So there's no fee. It's all sort of like, if you want to come, feel free to come. Just send me an email if you're interested. That info box is perfectly fine. And then we'll just make sure you get on the list. We have a meeting on Friday if anybody's interested.
Thank you, May. So I wanted to just take a minute between presentations and ask this question. And again, use your chat box and raise your hand. And we're going to do it fairly quickly because we're over time. How have you innovated or improved your utilization of technology to support community members or program participants' ability to access services during the COVID-19 pandemic? Before we asked about your colleagues, now we're thinking about the people that you serve. Just take a minute and type some things in the chat box and raise your hand if you have any questions, and I'll let Shane handle that. I'll thank Shane for putting in that. Anybody? Any ideas out there? One of the things that we did in the CASA program was our CASA program manager was sending emails out with ideas of how we could connect with our youth. We weren't allowed to be face-to-face, so they gave some ideas about using Zoom, using FaceTime, playing games together, real concrete ideas for CASAs that were really helpful. Didn't help me with my 14-year-old boy, but did help with some younger kids.
In a previous job, Barb, we used to do, when we used to do a lot of go-to trainings, we'd also have what we called open office hours. So it wasn't like, not everybody had to come. It wasn't concentrated, one concentrated topic, but it was like, we'll be here from, 9 to 10 a.m. Just to answer any questions that you have. So just kind of like opening it up. It's kind of like opening up your phone line, but, multiple people can ask questions.
That's great. I like that.
We've got some stuff coming in the chat box. Thank you. We've got Kelsey says, started recording my counseling sessions on worry and coping skills and posting on YouTube. And every kid in the county has access to it. Awesome.
That's awesome.
Patty says, help to link them to services and made daily phone calls. Dominique says, in general, I've become much more familiar with online platforms used to communicate regularly. We have to educate ourselves too sometimes, We're not quite used to it. We're not quite used to it yet. Phone conference Zooms. Again, we're Zooming with clients just like we are with our colleagues.
And Instagram, it looked like. I saw Instagram.
Access tech if they don't have it. That's a really big issue in education, right? Is making sure kids have a tablet or a vehicle of some kind to be able to get on, like Barb mentioned earlier, the digital divide. Texting, so texting with families that have cell phones. The WebEx meeting system to conduct family workshops, story time and readings, and personal phone calls. Good. Peer, so again, Zoom with the peer helpers, so encouraging peer-to-peer support in this time. That's a really great idea, because you don't have time to talk to everybody you need to talk to, I'm sure. So if you have some trusted participants that are trained, to help them, have them be involved.
I love to send gifts in the mail. That's a great idea. The old snail mail.
Yeah.
Don't forget snail mail.
Google Classrooms. I haven't used that, but that's great, and young people will know how to use that. Texting. Yeah. Heather says Head Start partnered with First Five to bring guest speakers in to address common concerns among parents. So yeah, it's really supporting parents. Yeah, an e-newsletter.
I like that.
Using an e-newsletter with community resources and updates. Guadalupe says recording videos with exercises and reading books. Great, thank you.
All right, I'm going to move on to the next presenter, and I will, I go through all of these, and I'm going to make sure, so keep them coming. I'll make sure to write them up and put them in our summary. And again, this will be recorded, so you can always go back and look at the chat box if you so desire. So our next presenter is going to be Patrick Kane from Central Sierra Connect, and he's going to talk about the digital divide. We're going to make you the presenter and make sure.
I have to unmute myself. There we go.
You're unmuted, and you can put yourself in presentation mode.
Great. All right.
Thank you, Patrick.
Can we see this?
Yeah,
there we go. Okay, great. Thank you. All right. So, hi. Just to introduce myself, my name is Patrick Kane. I'm with ATCA, and I run our Central Sierra Connect Regional Broadband Consortium, which is our it's our broadband program, and it's one of a bunch of regional consortia throughout the state. All right. Let's see here. Oh, how do I click through? There we go. So, a little background here. The California Public Utilities Commission set up a bunch of Rural and Urban Regional Broadband Consortia back in 2010, and then it was redefined in 2017 with some tweaks to the language about what is allowable and increased funding made available. That's a picture of the CPC, nice building. So there are 18 consortia throughout the state of California. I run the Central Sierra region, and it covers Western Alpine County, Amador, Calaveras, Tuolumne, and Mariposa as well. They're split up by counties. There are a couple that are just one county, but for the most part, there are a number of counties combined, and they are typically run either through an economic development agency, or there's a couple that are run out of state universities. Chico State has one, Fresno State has one, Humboldt has one as well. And we work to, next slide, achieve 98% broadband connectivity by household in each of our regions. And we do that in 3 different areas that we target. We work to build out more infrastructure so that we can actually expand what is available to folks. We work on adoption, trying to get more people to take advantage of what is there. And then through digital literacy efforts, working to make it so that more folks who don't necessarily take advantage of computers or mobile devices because they just haven't had the opportunity to learn how to use them, increasing literacy of how to use them. Let's see. So the first one that we focus on, infrastructure project and funding. Oh, and sorry, let me pause here. I know a lot of folks aren't from my region, and in the email, there's the list of all the contact folks for the different consortia throughout the state. And if after this you want help with your actual region, you can talk to me, or you can talk to the person for your region. So infrastructure projects, I work with local internet service providers and some of the bigger ISPs in our region to make them aware of funding and grant opportunities that become available. There's stuff from the federal government through the Connect America Fund. There's stuff from the state with the California Advanced Services Fund. USDA has a lot of money available for rural broadband. And we try and help guide ISPs through the process of applying for grant funding because it is expensive to get broadband to spread out rural households. It is cost prohibitive for most of these smaller internet service providers. So a lot of these grants are usually they're 50-50 matches, or some are 75. But now we're seeing some, thanks to the pandemic, some of the state and federal government grants are being offered at 100% funding because we need to get this out to people ASAP, because we have folks who can't avail themselves of telehealth, of working from home options, of distance learning, because the stuff isn't in the ground. And we need to get that to them as soon as humanly possible. The other side of the infrastructure project is we try and work with local and state officials to try and help bring together folks so that we can cut through the red tape that hinders these projects a lot of the time. In our region, we are working with supervisors and stakeholders from the different counties to streamline dig once policies, so that when someone tears up the side of the road to put in anything, they open it up one time and broadband is included in what is put down there. So we put a 3/4 inch pipe down there so that you don't have to tear the ground up again if Comcast or AT&T or some of the smaller folks want to come through. You just have to run it through instead of having to dig up the whole road. And that hopefully makes things a lot more affordable, a lot more accessible. And then as far as adoptions goes, we try to highlight for folks some of the affordable options that are made available to low-income individuals and households. The bigger companies, these are the ones in my region, Comcast and AT&T both have programs for low-income individuals. They have different criteria for what what your qualifications are to get these, but essentially, if you're getting some form of assistance, you probably qualify, and that can bring the cost of their internet to your home down from $90 or whatever dollars to $10 a month, which makes it a much more affordable and much more doable option for a lot of folks. So I try to go out there and promote these as much as possible. Unfortunately, some of the smaller internet service providers in our region and in most regions don't offer them because it's not something that they are able to do economically. And these bigger companies are forced to do this, and so they have to. So we have that option available for folks. The California Public Utilities Commission has this tool that we use at ATCA and that you can also use, which is really handy. It's the California Broadband Map. You go to www.broadbandmap.ca.gov, and I know a lot of times we don't say the www anymore, but this website is kind of screwy, and if you don't type it in, it goes to a different website. So that's really important to mention. I don't know why it's like that. But they have a tool on there called the address search, and you can type in a client's address if they come and are interested in these options, and it'll tell you what internet providers offer service at their address. They'll tell you mobile providers, they'll tell you fixed wireless providers, and they'll tell you wireline who is actually running internet to the home through the traditional long wire method. And once you see that, then you can walk them through the process of, hey, this is what's available. This one has an affordable option. This one doesn't, but maybe we can work with them. Oh, come here. And then our third area, and my favorite area, is digital literacy. We have a program called Coach and Learn, which it started many years ago and then kind of fell off, but then we rebooted it back in 2018. We originally only served one county, Tuolumne County, and we did it in partnership with the Tuolumne County Public Library. We expanded last year into Calaveras County and Amador County, and we're looking to expand into Mariposa County and Alpine this year. It's really fun. We try to keep it really flexible. Originally, when I started this, I tried to come in and say, okay, here's the game plan. This is what we're going to go over every class. And I found out very quickly that didn't work. We needed to keep it. We have a 2-hour class that these are booked for, and I talk for about 15 minutes before we take questions and then handle the issues that folks come in with. We see everyone from folks who don't know how to turn their device on to people who have very specific questions like, I want to download this attachment from work and print it, and it's this PDF that I don't know how to convert. So if I came in, I found out, with very specific goals, it was not at all what the students needed. We try to keep the class very limited, so we have about 5 to 7 people per class because they're bringing all sorts of different questions. And if I have 20 students with 20 different questions, we are suddenly running around, bouncing from person to person and not doing it as a class, which makes it very difficult. So we sit down, we have 5 folks, and they tell me what issues that they're facing with their computer. Susan comes in and she says, I want to download photos so I can share pictures of my grandchild with family. And then John says, oh, you know what? I wanted to print something from my iPad, but I also want to do that. So we end up doing the whole thing as a class, and people seem to get a lot out of it. We've had a lot of repeat guests, clients, and they just keep coming back and learning new stuff every week. It's been really great. Let's see here. As far as how you can help increase broadband in your various regions, this is a tool that you can download. It's from the California Public Utilities Commission. It is an app called CalSpeed. You get it on your phone and you run it anywhere you are. If you are in a dead zone somewhere on your route to work, you can pull over. Don't do this while you're driving. And you fire up the app. It'll test your connection and say, hey, you're in a dead zone. You're in a dead zone, your phone doesn't work here, it's not going to do anything right then. But then when you get to a real connection, your phone will upload that information to the California Public Utilities Commission. Why is this helpful, you ask? Because folks like Verizon and T-Mobile tell the California Public Utilities Commission, hey, we cover this area, we cover this area, we cover Calaveras County from here to here. And if we use this app and report our information back out to the Public Utilities Commission, they have that data, they have those dead zone spot information, and they can say, hey, T-Mobile, you say you do this, but in fact, I have 20 people who say there's a dead zone right in this spot. Fix that. So it really does help, and it really gets this so that we can have more people connected. We've done a lot in terms of getting more folks connected and trying to hit that 98% goal. Before I came on, we were at 72% in our region, and now we're up to 82%, which we're still not there, but we're growing slowly but surely. There's only 4, I think, 3 consortia throughout the state that have hit the 98% goal. And so all of the other 15 are still trying to climb and hit that number, which if you are out driving up and down the state of California, there are a lot of spots where you don't have connectivity, either through your phone or in folks' homes where they just can't get a connection to the internet. Let's see. These are my digital literacy classes. My favorite thing is taking selfies with them at the end of class. I just threw this on here because I love it and I had to share it with everyone. So thank you so much. And let's see. Let's see. I see we got.
Oh, don't worry.
Here.
It'll be taken care of. Carrie will. I just wanted to say.
Me off?
Yeah, she will move to me.
Great.
So 2 things. One is I apologize. I don't have Patrick's PowerPoint, but he's going to send it to me, and I will get it out to everyone after the event. And I would highly recommend you download the app. I downloaded it, and I did it in my house, and I was in a dead zone. I had to turn off the Wi-Fi, though, because with the Wi-Fi, I got the thumbs up. But then I turned the Wi-Fi off, and I got the thumbs down. So, anyway, it's a great app, and yeah, the more we can do that, that can help us to promote.
Big time.
Exactly. Thank you so much, Patrick. So,
thank you.
Any questions for Patrick before he? Oh, Tammy says Sierra County is a dead zone. The whole county, which is a big problem for her. I mean, during the COVID-19, that's been her biggest issue. That's Loyalton, up in that area, which is, I don't think that's in your region. Oh, and that's the other thing is, I did email out the regional consortia, but I will put that in the email for folks.
Great, thank you.
Oh, now here's a question for you, Heather. Where would we send feedback about the app? I've tried using it and had some issues.
That is a great question. I guess you could rate it in the App Store and tell them there are problems, but that's probably not the most efficient way. You know, I don't actually know the answer to that. I can find that out, and maybe we can include that with the slide.
Excellent. Thank you so much. Perfect.
Great.
Good question, Heather, when you stumped the speakers. So thinking about what Patrick talked about, and I know Tammy, it's a huge issue in Sierra County, as well as many of the other counties that are rural here in California. So there are these places where people don't have access to broadband. Are there any strategies that you folks have used to promote equity for your constituents in accessing, technological services during the COVID-19 pandemic, besides snail mail? So we'll take just a minute and think about that and see if we get any responses in the chat box.
So Barb, this is Carrie, we do have one hand up, Pat Porto.
Hi.
Does Pat want me to, I will unmute you, Pat, if you want to ask the question. But you are self-muted, so you need to unmute yourself, unless you didn't mean to do that. Oh,
yes.
She put it in the chat box.
Oh, Pat, here, let's see here. I just saw some really good questions. So Patty Rommel said that they set up school buses as Wi-Fi hotspots, which I've heard other places have done as well. I've during the COVID-19, I've heard a lot of parents having to go to actual parking lots to do work with their kids. But that's a great idea. Shane, do you want to do the chat box?
Pat just asked, I'm not quite clear on the question, but would this be appropriate to share with clients, to do for themselves too, and for them to continue to share with family and friends? Are you referring to the app, Pat?
I think so. Yeah.
Oh, I'm sorry. It does say that. I'm referring to the speed download app. Yeah, I think so. I think that's a great resource to send out to folks. Chelsea says we keep our office open for one youth at a time to come in and use our computers.
That's a great idea.
I know that's a big issue for, I've been involved with a group in Fresno County the past 2 months, and they've had, the community college district has had a lot of people dropping out of classes because they just aren't, they either don't have a place to study anymore because they can't go to the library, or they can't go to the school, computer lab, and they're just really struggling with the online learning piece. So yeah, if you have any resources like that for your your college students, that's helpful. Might help them not drop out.
Yep. Any other? Oh, Patrick had, just like Patrick said.
And Jennifer shared the CalSpeed, has shared that CalSpeed app at outreach events and the flyer. Yeah, great.
That's a great idea. All right. Well, now, last but certainly not least, let's move on to Ian, because we're, I think you'll be fine, Ian, hopefully time-wise. So, Carrie, if you could, there you go.
Yes, I just made Ian the presenter. Nice, Ian.
So, Ian Costello is from the Corporation for Supportive Housing, and take it away, Ian.
Great. Hi, everyone. let me just get situated here really quickly. And I have a timer for myself, so I'll try to keep us, I'll try to get us back on track here.
We went over a little bit. Sorry about that. But
No worries.
Thank you.
Great. So hello, everyone. Thank you so much for having me. I really appreciate it, being able to share my experience with HMIS and the Frequent User System Engagement Model. My name is Ian Costello, and I am a program manager and data analyst with the Corporation for Supportive Housing, and I'm stationed normally in downtown Los Angeles in my office, but today coming live to you from my living room in Pasadena, California, where it's a little overcast today. So my background, I used to work at, I was really happy to know who's in the virtual room today. My background is in the continuum of care HUD world. So I used to work at the Los Angeles Homeless Services Authority, which is the COC lead agency here in Los Angeles County. And my role there was as the manager for performance management and reporting. And that included all of the HUD activities that we had to accomplish. So the point in time count and the housing inventory count, if you're familiar with those things, that's something that I was involved in, as well as leading on the system performance measures. And if you're in the COC world, then you know about the NOFA, and that was my bread and butter as well. So I have a lot of experience in reporting and also in working with the HMIS system. And I want to just level set a little bit to explain to everyone what HMIS is, how it's used normally, and then how we can move past those normal uses into things that connect to other systems and help us get a much better understanding about who's experiencing homelessness in our community, as well as who is cycling through these cross-sector engagements, whether it's health, where people are going through, the federally qualified health centers, or going into acute care with hospitals, and certainly cycling through the justice-involved system, prisons and jails. And so I'll explain what that cycle might look like, and then how HMIS, as well as other data systems within those sectors, can end those cycles for folks. So first off, HMIS, a lot of acronyms coming at you, but HMIS is the Homeless Information Management System, or Homeless Management Information System, actually. And it's a HUD required platform. So if you accept HUD money within your community, and virtually, the entire country does, you have to have a system designated for that jurisdiction. Again, we call those COCs, or continuums of care. You have to have that system so that all of the homeless information that you collect from participants, demographics, program and services that are provided, entries and exits, and also vulnerabilities within your assessments. A lot of communities work with the VI. So that, as an example, Los Angeles does that. All of that can go into the HMIS system, and then be tracked across time, and then also across providers. So the main benefit that you see within HMIS that are so-called open systems is that you can see a lot of responses for participants that they have responded to questions from other places in the county. So, for example, I run a emergency shelter, and I see a lot of people every single night. As people come in, HUD requires you to answer certain questions, universal data elements are what they're called. And if you don't answer those questions, then there's a data quality thing, and further down the line, you get a huge headache in findings and monitoring and all that stuff. So to avoid that, you ask all these questions and plug them into the HMIS system. In an open HMIS, and the majority, I'm fairly confident the majority in California are open now. You have Joe Smith come into my emergency shelter, and I say, welcome. Please, have you been in the system before? You can look the person up, and then all the responses that the person had made, this Joe Smith has made, are immediately visible to you. So you can know how they responded to the question regarding race and ethnicity, how they responded to questions around when they first started experiencing their current episode of homelessness, as well as all their really personal questions potentially. so it not only just speeds operations working with an HMIS system, because you can get through the intake really quickly, and oftentimes that's maybe the process bottleneck that a lot of particularly interim housing programs have. But you can also limit the trauma and re-traumatization of folks that are coming into to receive services by not having to ask them these questions over and over and having them retell their stories over and over again. That can be, really detrimental to both the person that's doing the intake and certainly the participant that's coming to seek services. So HMIS, I'm a huge evangelist when it comes to HMIS. I really think it's one of the critical infrastructure pieces that a community can have, not only for process-based at the point of care, but also from a community standpoint where you can begin to see trends and prevalences of certain social determinants of health that go into the system. So
Ian,
yeah.
Can I just interrupt you for a second? I don't know, the slides are not moving.
I haven't moved them yet.
Oh, okay. I just wanted to make sure. Okay.
Sorry, that's me just spieling. Sorry about that. I will advance them now. So, but that's a good that's a good cue for me to move on. So, and I can, I'm happy to talk more about HMIS at the end. So, one of the things that HMIS can be used for, and another thing that I'm a huge evangelist of, is the FUSE model or FUSE approach or FUSE program, whatever you'd like to say. And so what is FUSE when it comes down to it? So the FUSE is the Frequent User Systems Engagement, and it's a nationally recognized model. It started in New York City. My boss actually is one of the first people that worked with the FUSE, a FUSE-like program in New York City. And it came actually out of an elevator conversation, as some of, most of these things happen is just by sort of happenstance. And the commissioner for the jails and the commissioner for housing were taking the elevator, and we're arguing about, who is seeing each other's clients. So like the housing person was saying, well, you have all these folks that are coming from the jail and they're coming into the housing system and we have to take care of them. And then the jail person was saying, well, you have all these people that are experiencing homelessness and they're coming into the jail. They said, well, so sort of to prove the point, they said, well, why don't we compare notes? So they had an extract from the jail and the extract from the HMIS. They were able to overlay that, and it was stark to see, wow, like we're actually seeing a lot of the same people. And as you know, it's one of another crisis that we're experiencing is that jails are becoming the largest provider of mental health services in the country. Many community jails, small and big alike. Los Angeles is certainly not immune to that. Our jail is certainly the biggest mental health provider in the county, and that's just not right. And so FUSE comes out of that notion of that people that are cycling through these systems may not necessarily should be in housing rather than cycling through those systems. So FUSE helps bring those systems together in a meaningful and durable way, so that we can identify who is experiencing these frequent engagements and prioritize them for housing. Okay, let me advance the slide here. So I may have gotten a little bit ahead of myself, but as people go through these systems, we're really wasting a lot of resources and money, sort of chasing our tails, where we could just figure out, if we could just figure out who are the folks that are cycling through the most, and costing the system a lot of money, plus the deep impact that someone has going through homelessness over and over, jail over and over, and healthcare over and over. There's a huge human cost to that, as well as just a cost economically into society. So being able to identify where those costs are can help prove to CFOs and accountants like why this makes good sense, as well as to political leadership as well. So again, FUSE is a very cost-effective solution. It draws together different housing services as well as treatment services from across the sectors to target those that are frequent users across health justice, and housing. A typical frequent user may look like this. So you see the purple here relates to the HMIS data. Oops, sorry. I just got my thing crashed here. Sorry about that. Oops, too far. So the frequent users, in this case, the purple here corresponds to the HMIS data, the homeless system data. The grayish color here represents justice system or jail. And then the orange here is around health. And so health isn't just monolithic, as we've learned through my colleagues presenting as well, is that there's a behavioral health element, there's perhaps an emergency element as well, and so all of that would be maybe included in the health side of things. And then the last thing, at least in this case scenario, is an unknown. So this is a real frequent user. FUSE programs generally, because of HIPAA and other reasons, normally start off with the justice component rather than starting with the health component. But I think in my experience, health centers and certainly hospitals are much more, insurance companies are much more keen on data sharing and data integration if it's done correctly. Consult your lawyer, all that good stuff, to make sure that it's all above board and in compliance with HIPAA. But given all of those things, I think health partners have become much more cooperative and see the value of connecting their data to other systems. So frequent users in healthcare, there's a cost avoidance that I was talking about. Insurance companies are quite keen, particularly on the FUSE program. Medicaid systems, we've pitched the FUSE program to those, and there's been a lot of studies around how particularly emergency use, emergency services use, ERs, ambulance transports, police call-outs, have been reduced by using the FUSE program and targeting it to those that are that have the most system contacts. And they may not, and that may not overlay with those that are experiencing chronic homelessness, for example. And that's one of the this is my timer telling me I'm done. That may not overlay with those that are experiencing chronic homelessness. The deeply entrenched folks that are on the street that have been outreached to many times, but haven't been we haven't gotten them successfully placed into permanent supportive housing or permanent housing, and so this population of frequent users can sometimes fall through the cracks because many communities are focused on ending chronic homelessness, ending veterans homelessness, and so this population sort of goes unnoticed because they are able to disappear from one system and appear in another. And so by creating these networks of data integration, data sharing, you get a much more complete picture of who's where. And I'll try and these slides will definitely be made available to you later. So I'll just try and get to a few other things about how to get started. So FUSE is a process, and we've actually laid out a lot of action steps. So we think about it in 3 phases: the planning phase, the pilot implementation phase, and then the scaling and replication phase. A lot of people get stuck on planning, as is I think normal. I think one of the major steps, the first step here that we've listed, is to identify a champion and project manager. That could be political leadership, that could be a sheriff's deputy, that could be a commissioner or the COC board lead, or just like a really good cheerleader in the community to get stuff off the ground. And that's really where I think we would want to emphasize where to focus your time is trying to get someone that believes in data sharing and believes that FUSE and that targeting those that are frequent users of these sectors to reduce costs and also end people's cycles of homelessness is important. Let's see. So these are some of the successes that that have happened across the board. One of the things that I think you should look out for, and I'll be able to pass on some information later on, is in Montana. And there's a great consortium of communities in Montana, very rural, very spread out. So not unlike this group here, I think, that have been working with the state that has a very robust data platform to get FUSE off the ground in all of those communities. I think it's like five FUSE communities across Montana. So it's really exciting work. And you can certainly look on our website for more evaluations on how FUSE works and how people got started. And I'm happy to make myself available to point you to those resources. This is just a quick how sort of this is in Los Angeles, the 10th decile project, the highest cost, highest need, 10% of homeless individuals. Very simple program model, but there's more complexity when you look at these steps individually. And I encourage you, I can make the evaluation available to you if you want to read it. This is far more detailed, and this is just here so that you can take a peek later. So some of the advantages and challenges, it's a very flexible model, so you can really make it what you will, and you can use the funding sources that you have. You have to have very clear project leadership and buy-in from the sectors. Again, that's I think where the champion comes in handy, where you can have someone really in your corner that has some clout to get people to the table. That's probably one of my biggest pieces of advice is to be patient when starting something like this, and to find someone who is indefatigable. So some other considerations, I think this is a great place to put this presentation after my colleagues also presented, particularly in light of the COVID crisis that we're experiencing right now. There's a lot of change coming through our health center. There's also a lot of changing demographics. Our state is trending older. And so that's one of the critical concerns that I think we're all watching in all of our sectors and all of our work, and how that affects our work. So that's something to be mindful of, as well as the changing funding and policy landscape. CalAIM may bring some new opportunities and challenges to a FUSE program, for example. So where to start? So if you don't already know about HMIS or know who your HMIS person is, I really think you should reach out to your COC, get connected, see if HMIS is right for you and your programs, particularly if you're not participating in HMIS and you do serve those that are experiencing homelessness. You may talk with them to say, hey, should I be on HMIS? How would it benefit me? Every community is different, so I really encourage you to reach out to your COCs. Health and information exchanges and those that run them are also good places to start, as well as just like looking at who you refer to or who people refer to you. If you're running programs, and say like, gosh, I wonder how where's the overlap between the populations and the people that we serve. So maybe a one-time match could help get things into gear. Sometimes by saying, by just doing a one-time match, obviously with all of the data use agreements and paperwork squared away, but by seeing who you serve and who you have in common, that can lead to other ideas and other things. And that's where we've seen in a number of communities across the country where things really start to take off, is after they get the one-time match in order. And maybe it's between, the justice sector. So you're able to compare who goes through jail or prison, for example. Those data sets usually aren't as restrictive because they're often public anyway. And again, find your champion. So someone who's really good in your community, a good booster, a good cheerleader, and someone with some political clout. I also want to just plug our training center. We have right now a free platform related to the COVID-19 crisis. All you have to do is sign up for an account, and there's a ton of resource and policy guidance. A number of tools. I created a tool around budgeting and expenses, so that if you have to hit up your funders later on for reimbursement related to costs for COVID, you can have all of that tracked and documented in one place. So please do check it out. And with that, I will end my presentation. Thank you so much.
Sorry that you had to rush through like that. Ian, I do have one question for you. How did you overcome, or how do these FUSE organizations overcome restrictions on sharing client data? Do they have like a form that the client signs?
Yeah, everywhere is a little bit different. So releases of information are making sure that all of your documentation lines up, and that everyone is aware of what the requirements are. So releases of information, things that the client sign, from an HMIS standpoint, that is required. But each community has different, from the COC standpoint, from an HMIS standpoint, each community has a different privacy plan that allows you and disallows you from doing certain things. So honestly, it's the paperwork is maybe the easy part. Getting people just to agree that yes, data sharing is a good idea is often the hardest part. So everyone's a little bit different. And also just being like, I think knowledge is power. And so understanding exactly what the requirements are for data sharing is the best solution, because then you can facilitate those conversations, say, well, actually, it's allowed, or this is what the law says. Obviously, if you, I can't say enough to contact your attorneys. They're very helpful with that. So, and also getting a good lawyer. So having a lawyer that believes in this cause, that says that is willing to work through the risk and manage it is really important too. Okay.
So get a lawyer. Always a good advice.
A good one.
So thank you, Ian.
Sure.
So
thank you.
After Ian's presentation, I was just wondering if anyone had, my reflection question for you all is, has anyone used the HMIS system or another shared client database to connect agencies to support families or individuals in your community, whether it's around homelessness or another area? Oh, and here's somebody, we have an answer. Oh, Denise. Hi, Denise.
She said it's shared through California 526 through 4 hub stations.
Oh, I don't know what that means. But
I know. Can you, Denise, can we unmute you and you can tell us about that? Maybe?
I think so. It should be cool.
Yes. All right. So I'm going to unmute Denise, but she is self-muted. She's self-muted. I think I just sent her a pin. We'll give her another second. So Denise, you're self-muted, so we can't hear you.
Well, Denise, if you want to just chat and then we can review that.
Yeah, that's fine too.
Because I know we're running. I'm anxious to close on time, and I recognize that folks have things to do and places to go. So I think she's unmuted. Oh, okay.
Denise?
I don't think so. All right. Well, if you could just chat what those are, Denise, that would be grand, and I'll make sure to put it in the finish in the materials that I send out after the learning community. So I just want to encourage folks to register for Part 2 on May 21st, because if you register for Part 2, you'll get an email on Monday which gives you access to the Our Voice app, and we're going to have you do a little walk about your neighborhood, and you can become a citizen scientist and have an opportunity to practice using the Our Voice discovery tool, and then upload the information. And then when we're on the webinar next week, and Bangkok will take us through how you can utilize that application. It's really, really fun and very innovative. So please register so I can get that information out to you. It is at 10:30 on Thursday, the 21st. Okay, and I just want to share with you what's next for the learning communities, because, as I said, we're not going to be, in the fiscal year beginning July 1st, we are not going to be connecting regionally with the learning communities, but rather strategies will become a TA organization, and we're going to have conversations that are focused on county prevention planning, child abuse prevention. So we encourage you to stay connected with each other, stay connected with your local child abuse prevention center, your family resource center, and child welfare, because we hope we can continue to work with you, and we will have learning communities as a part of our collaboration, but not specifically these type of events that we've had. And I have a poll question for you before you run off. I'm planning in June to put together a go-to training like this, where I share some of the things that we've garnered from all of our learning community facilitators. There's 6 of us across the state. What makes a learning community a learning community? So if you're interested in participating in an online meeting like that, let me know. Yes, no, maybe so. I'm just taking your temperature. And then I'll plan something for June, and I'll invite, I have a fairly large mailing list that I will mail out to. So I think the poll is open.
It is open.
Thank you, Carrie.
Mm-hmm.
Vanessa's interested. Yay!
Yes, if you cannot click onto the poll, please put your answer in the chat box, and Barb can know then what's going on there. Just only 35% of you have voted so far, but I'm going to close the poll in about 10 seconds.
Okay.
Probably hear the airplane behind me.
I did. That was, yeah, I've got a few yeses coming in here. Great, thank you.
5, 4, 3, 2, 1. And let me share those results. So, it's about half and half of yes and maybe so, but
okay.
No, that's a good one.
Okay. That's great. All right. Well, I will be in touch with folks about that in the future. And I just wanted to say again, thank you so much. Thank you all for your support of the Learning Community Project over the last 4 years. It has been my honor to be a facilitator for all of you. You guys have been wonderful. And you all know who you are out there. And I want to say stay safe and healthy. Take time to do an evaluation. It should be emailed to you after the webinar. And I want to thank my presenters and everybody who's been involved in the program, Shane and Carrie, Judy Sherman, who's on the call, and Anvi, all my support. Thank you all so much. And we're going to say, see you later. Wash your hands, especially after this.
Bye, everybody. Have a great day.